Today we'll be speaking on X-ray palmistry. It may sound mystical, but systemic disorders, several of them reflect upon the hand X-ray. Remember, Ranjan for the first time has taken his wife's X-ray when he discovered the X-rays. Apart from historical interest, the interest upon taking X-rays of the hands and evolving diagnosis by logical reasoning is important. Why? Because X-ray of the hand is simple, it's not high-tech. It may be taken even in a rural area with a portable X-ray. That's why today I'm concentrating on radiography of the hands and how we can diagnose various systemic disorders. I'm eliminating local disorders like trauma, maybe local infection, neoplasms, benign or malignant, but concentrating on systemic disorders. And there must be a method in teaching various systemic disorders. First is congenital or developmental dysplasias. Amongst those dysplasias, look at the X-ray first. As I said earlier, X-ray palmistry is not a mystery, but it's all logical reasoning depending upon the various radiographic findings. 1895, it was Wilhelm Conrad Röntgen that has discovered the X-rays, and then he has taken his wife's hand for the first time in order to depict various bones. And following a method, congenital or developmental abnormalities, first of all, we take sclerosing dysplasias of the skeletal system, osteopetrosis, osteopycnodysostosis, Pycnodysostosis, Melrheostosis, Engelmann's disease or Epiphyseal Dysplasia, and Idiopathic Hypercalcemia. Osteopetrosis, as all of you know, osteopetrosis is otherwise also called marble bone disease. It has got a distinct radiographic finding, although there are 2 or 3 varieties of manifestations, but first thing is diffuse sclerosis of the hands. And if you look at the hand bones, there is an inset, a miniature inset of the original bone. That's what is called a bone in a bone. It is one of the characteristics of osteopetrosis. And then we come to Pycnodysostosis. It is also a dense sclerotic bone disorder, but the difference between osteopetrosis and osteopycnodysostosis is it is a hybrid between osteopetrosis and so-called cleidocranial dysostosis. That's why there are certain combined changes. One, of course, diffuse sclerosis that is common to marble bone disease. Second, there is acroosteolysis. Look at the distal phalanges. They are tapering. Sometimes they may even disappear. That's one of the major differences between osteopetrosis and pycnodysostosis. Also look at this hand. Again, here also you can see a bone in a bone appearance. And then we come to the entity called Melrheostosis. It is a wax flowing in a burning candle. And here you find there is no uniform density of the bones, but the segmental sclerosis of the bones associated with soft tissue ossifications. Look at the index finger on the left hand and also the ring and little fingers on the other side. Sclerosis, apart from sclerosis, that sclerosis also is not uniform. It is marginal sclerosis with hyperostosis and soft tissue calcifications or even ossifications. Then we come to the entity called Engelmann's disease or progressive diaphyseal dysplasia. This is restricted only to the diaphysis, diffuse widening, hyperostosis, and sclerosis only at the diaphysis. Sometimes the base of the skull also may be involved, at which time we'll call them craniodiaphyseal dysplasia. Then we come to the osteopycnosis. The osteopycnosis is a spotty bone disorder. Multiple dense, small islands of bone are seen. Actually, if there is only one, we call it a insular compacta, or this cortical bone insulated in the spongiosal bone, or bone island also we call it. Here there are multiple bone islands, and most of these are juxta-articular on either side of any joint. Then we come to the diagnosis of idiopathic hypercalcemia. Who don't know the reason, but it's congenital or developmental. And then here also you get dense diffuse sclerosis of the bones. And one major difference between the other marble bone disease and all that is there are some areas of lucency because it is developing and almost it resembles a secondary hyperparathyroidism. Then dysplasias, epiphyseal dysplasia, spondyloepiphyseal dysplasia, metaphyseal dysplasia, spondylometaphyseal dysplasia, fibrous dysplasia. All these again are systemic disorders, although fibrous dysplasia could be monostotic, but the rest of the others are diffuse, involving the epiphyses and spine. Look at these epiphyses. They are short, flat. Look at the radial epiphyses. Similarly, the epiphyses of the phalanges and metacarpals are flat and small and short. This is epiphyseal dysplasia. Spondyloepiphyseal dysplasia means there is dysplasia involving the apophysis of the vertebral bodies also. You can get isolated epiphyseal dysplasia or you can get spondyloepiphyseal dysplasia. If spondyloepiphyseal dysplasia with polyarthropathy, almost simulating a rheumatoid arthritis, also another entity, it simulates rheumatoid arthritis, but there are no erosions of the articular ends of the bones, which you see in rheumatoid arthritis. The metacarpal heads are large, not small, as we found earlier, and soft tissue changes, that is, namely swelling of the soft tissues, again simulating some sort of a arthritic process. Look at these hands. Almost in the first look, it looks like a rheumatoid arthritis. On the closer look, you don't find any erosions. You don't find any subluxations. All you find is spindle-shaped swelling of the joints with large metacarpal heads. Another case where this simulates rheumatoid arthritis, whereas that one is earlier adult, this is a child, about 10-year-old child, simulating rheumatoid arthritis. In the sense, there is para-articular osteoporosis, enlargement of the epiphyses, which you find in juvenile rheumatoid arthritis. Then the other entity is spondylometaphyseal dysplasia. Again, here also there may be peripheral arthropathy, retarded carpal and tarsal bones, large articular heads, as you saw in spondyloepiphyseal dysplasia, degenerative changes. As time goes on, these epiphyses do produce, because they are adjacent to the joint, degenerative changes, and then metaphyseal changes too. This is the spondylometaphyseal dysplasia. Look at the carpal bone. There is osteoporosis of the bones. There are large metacarpal heads, and then early degenerative changes, namely the narrowing of the spaces between the metacarpal phalangeal joints, intercarpal joints, and radiocarpal joints. Now we come to the entity called fibrous dysplasia. Of all these entities which we mentioned amongst dysplasias, fibrous dysplasia is the most common. And then what are the radiological findings? You can get mixed osteolysis and sclerosis, fractures, pseudoarthrosis, deformed limbs, and modeling deformities also. And fibrous dysplasia could be monostotic, polyostotic, or the so-called Albright's disease, where it occurs often in girls with premature precocity of sex, and then unilateral distribution mostly, but although it may be asymmetrical. This is, for example, polyostotic fibrous dysplasia. As soon as you look at the picture, it looks as though it is a multiple achondromatosis. But if you look carefully, there is expansion of the bone, ground glass appearance of the bone. Occasionally you may get small calcifications, which is called fibrochondrodysplasia, but that entity is rare. We are talking about fibrous dysplasia. Again, another example of fibrous dysplasia, diffuse thickening, ground glass appearance of varying sizes of varying bones, not necessarily symmetrical, but bilateral and polyostotic. And occasionally, fibrous dysplasia may be associated with rickets in children. That is explained by some sort of production of a humor, not a hormone, humor, which produces rachitic changes, osteomalacia in adults and rickets in children. Now, mucopolysaccharide disorders, this is an ocean. Nobody fully understands what these disorders are, and they're not logical, clear-cut, although some sense could be made out from radiological and clinical findings. More often, they are superimposed on each other. They may be mixed. Since it is a syndrome, so all the constant radiological signs may not be present all the time. Some of them will be present some of the time. But you should make out all the 6 or 7 varieties of mucopolysaccharide disorders from radiological findings only. Hunter. This is more or less classical. Look at the pointed ends of the metacarpals and then inclination of distal ends of radius and ulna and thickening of the soft tissues. This is a picture of Hunter disease. Whereas Marfan, here also there is pointing ends and more pointing of the distal end of the radius and ulna. Almost sometimes simulates rachitic changes, but this pointing is not present in rickets. And also there is retarded bone age as noted by only 5 carpals in an 8-year-old child. Hurler syndrome, hands proximal pointed MCs. In all these, if you look at, some of them are bullet shaped, some of them are really pointed at the proximal end, irregular small carpal bones with delayed maturation, and surfaces, radioulnar surfaces, slope towards each other. If you look at all these, some overlap of radiological findings is there, but then you have to find out which mucopolysaccharide is there from the examination of the urine and some genetic studies. Here, another classical example of Marfan, and see the pointed ends and similar inclination of the radius and ulna towards the midline. And then we come to other syndromes. We have finished the sclerosing dysplasias, other dysplasias, mucopolysaccharide disorders, now other rarer syndromes. CCD, Cranio-Cleidodysostosis, and then Ehlers Van Creveld, Turner syndrome, Marfan syndrome, Mongolism, Trisomies, Rubinstein Taybi syndrome, Fanconi's anemia, Holtarum, myositis ossificans progressiva, or today it is called fibrocalcificans progressiva, Fanconi and Ditoni syndrome. Of course, we have finished mucopolysaccharides already. Fanconi's anemia. In this anemia, look at the hypoplastic thumb. The phalanges are hypoplastic, even the metacarpal is hypoplastic. It may be unilateral, it may be bilateral. This is Cornelia-Ardili syndrome. That is very rare. But what are the radiographic changes? One, you see the short first metacarpal. That is important. Occasionally you may get a polydactyly. Tricarcinophalangeal dysplasia or Gideon's disease, where there are some changes in the upper nasal tract, and of course changes in the coned epiphysis is important. You look at some of the phalanges, you find the coned epiphysis. Arthrogryposis, congenital dislocations of various joints, hips, knees, including metacarpophalangeal joints. Arthrogryposis, generally, slender bones, dislocated joints, as I said already, carpal fusion, and rocker bottom feet. Rocker bottom feet means there is a vertical talus and the calcaneus is convex downwards. Now we come to the Poland syndrome, hypoplasia of pectoral muscles, supernumerary nipple, hypoplasia of the phalanges of the hand. Poland syndrome, there is a clinodactyly of the little finger. And then we come to polydactyly. We can get various conditions, oversegmentation, June syndrome, condoectodermal dysplasia, or otherwise called Ehlers Van Creveld syndrome, Trisomy 13, Carpenter syndrome, Lawrence-Moon-Beadle syndrome, where there is polydactyly, mental retardation, and some renal changes. Pachydermo Periostosis, another idiopathic type of entity where you get thick skin and diffuse periostal reaction, clubbing of the fingers, and folds in the frontal skin, almost simulating acromegaly. Rubinstein Taybi syndrome with congenital heart associated. Look at the short or split distal phalanges of the thumbs. Same thing occurs in the toes also. Short and wide terminal phalanges of thumb and great toe. Short, wide and tufted terminal phalanges of the fingers. Flaring of ilia, retarded bone age, either ASD or VSD, and occasionally you find urinary tract anomalies. Trisomy 17, 18. Look at the ulnar inclination of the index finger at the interphalangeal joint and ulnar deviation of the fingers. This is supposed to be classical of trisomy 17, 18 syndrome. Ulnar deviation of digits, V-shaped deformity between second and third digits, classical, and flexion deformity, of course. Marfan syndrome, it is a clinical syndrome, of course, with several features. A tall figure, long, slender phalanges, as you see here. Long, slender fingers, slender bones, elongated proximal phalanges, and occasionally find contractures of the joints. Ehlers Danlos syndrome. Earlier we have mentioned chondroectodermal dysplasia. For the first time in India, we have described from Neuro Hospital 2 cases. Hypoplastic distal phalanges, postaxial polydactyly, syncarpus, syndactyly, small pelvis, flat acetabular roofs. 60% do have cardiac anomalies, either ASD, VSD, or other anomalies, single atrium or large ASD. This is one of the classical examples of as soon as you see there is polydactyly and there is syncarpus. That is important in diagnosing this entity. Another, notice the syncarpus, capitate and other bones are fused and there are 6 fingers. Another entity is peripheral dysostosis. It's only restricted to the hands and feet. Short metacarpals, short phalanges, and few metacarpal bones are a little broad and wide. But this shortness of metacarpals and phalanges is classical. Same thing occurs in the feet also, short metatarsals and phalanges. Now peripheral dysostosis, Brailsford has described it first. Epiphyseal acrodysplasia means distal dysplasia. Premature closure of growth plate, that's why the bones are short. And then short hands and feet not only occurs in dysostosis, acrodysostosis, but you can find in achondroplasia, Ehlers disease, mucopolysaccharitis, particularly Hurler, Hunter, Marcos, which we have described earlier, hypochondroplasia, and of course in peripheral dysostosis. Other entities, pseudo-hypoparathyroidism, Fairbank disease, which we mentioned earlier, epiphyseal dysplasia, diastrophic dwarfism, Ellis-Van-Creveld syndrome, Noonan syndrome, and Prader-Willi syndrome. These are the rare syndromes where you can get short hands and feet. Cleidocraniodysostosis. You remember earlier we said regarding Pycnodysostosis, it is a hybrid between marble bone disease and cleidocraniodysostosis. In the sense, cleidocraniodysostosis also you can get tapering distal phalanges or occasionally acroosteolysis. And here, the accessory center for the second metacarpal at the base is another important sign. Relatively long second and fifth metacarpal bones, short middle phalanges, and supernumerary ossicles. This is the one example of accessory ossification center at the base of the second metacarpal. That's why it is long. And now we come to idiopathic acroosteolysis. So far we have mentioned several cases where you get acrosteolysis, for example, in Pycnodysostosis, cleidocranial dysostosis. Now, it could be idiopathic phalangeal, tarsocarpal with nephropathy, and multicentric acrosteolysis. Another entity where you can get acrosteolysis, namely tapering or disappearance of the distal phalanges, is polyvinyl chloride poisoning, which occurs in radiographers or darkroom workers where in X-ray department where they polish the polyvinyl tanks with their hands and they may get this poisoning and acrosteolysis. Ehlers Danlos syndrome, where you get a multiple flexibility of the joints, mobile joints, and then you could see here in the fourth finger there is a short fourth and fifth metacarpals. Apart from that, there is subluxation at the proximal interphalangeal joint of the ring finger. And then there is another entity called Chloride disease, where there is Chondrodysplasia calcificans congenita. Look at the multiple calcific centers in the carpal bones. This is classical of Chloride, but this may also, you may find, say, in children where the mothers have taken anticoagulant therapy like Coumadin, warfarin, heparin, etc. The next entity we are talking is about phacomatosis. In this there are 5 or 6 entities, but we will restrict ourselves to angiomatosis, so-called cystic angiomatosis or hematomatosis, epiloia, tuberous sclerosis, and Neuro Fibromatosis. There are others like Sturgeover syndrome, ataxia, and all that. Tuberous sclerosis is also called epiloia. Clinically, it has got a triad: adenoma sebaceum, seizures, and renal hematoma. Mental retardation also clinically you may find. Tuberous sclerosis, what are the changes? You find multiple hematomata, even in the bones, subcortical pitting, and look at the phalanges of the third finger, cortical scalloping. These are all due to hematomas in the subperiosteal or cortical areas. Neurofibromatosis, there are 2 types, neurofibromatosis 1 and 2. In neurofibromatosis type 1, you get hypertrophy of the bones, atrophy of the bones, erosion of the bones, cystic changes in the bones, all sorts of varieties you could see in the hands. Hypoplasia of the distal phalanges on the left side, and the right side is the foot. Look at the hypertrophy of the second metatarsal and phalanx, and at the same time atrophy of the lateral phalanges. Now we come to the important entities, because often clinically whenever they suspect a rheumatologist or an orthopedic surgeon or an internist some arthritic process, the immediate thing they ask is for radiography of the hands. And what are the clues that we can get? What are the diagnoses we can get in various arthritis? Osteoarthritis, and a type of osteoarthritis is erosive type of osteoarthritis, rheumatoid arthritis, including juvenile rheumatoid arthritis, psoriasis, gout, and in children, congenital type of gout, leishman hand disorder, pseudogout or chondrocalcinosis, and collagen vascular disorders such as lupus and mixed connective tissue disorders. And this is classical of so-called osteoarthritis, primary osteoarthritis, because secondary osteoarthritis can occur after trauma, infection, inflammation, and other disorders. But this primary osteoarthritis, where you find distal phalanges for some reason or other, the interphalangeal joints, distal interphalangeal joints are involved, namely narrowing of the joint space, evernation of the articular surfaces, and also osteophyte formation. This is clinical Heberdine's notes. Those osteophytes produce swellings, soft tissue swellings in the distal interphalangeal joints, so-called Heberdine's notes. Again, osteoarthritis also in hand somehow prefers the first metacarpophalangeal joints. Look at this mild subluxation, narrowing of the joint space, and osteophyte formation in the thumb area. First metacarpophalangeal joint. And then, as I said earlier, there is another variety of osteoarthritis, often occurs in postmenopausal women, and sometimes it is familial. And what is the importance of this? There are erosions, as if it is a combination of rheumatoid arthritis and degenerative arthritis. But these erosions are mainly in the interphalangeal joints and distal interphalangeal joints, proximal and distal. And metacarpophalangeal joints are rarely involved. And you don't get para-articular osteoporosis, which you get in rheumatoid arthritis. That's the importance. And of course, the first metacarpophalangeal joint, carpometacarpophalangeal joint, these are also involved in this. Again, another examples of erosive osteoarthritis. Look at those erosions, and also destruction of the cartilage, which is seen by the narrowing of the joint space and osteophyte formation. Sometimes, given only one finger, you can't really differentiate from psoriasis because there is no para-articular osteoporosis. There are erosions. There is narrowing of the space. Rheumatoid arthritis. Classically, in acute or subacute rheumatoid arthritis or acute exacerbation of the chronic rheumatoid arthritis, you get para-articular osteoporosis. That's first. Second, there are swellings, symmetrical swellings at the metacarpophalangeal joints and interphalangeal joints. Third, erosions, peripheral to start with, and ultimately it surrounds the articular margin. And finally, it's a most or less a synovial disorder to begin with, and then finally the cartilage also is involved. That's why there is narrowing of the joint space. Another example of rheumatoid arthritis, peripheral erosion, dot and dash appearance at the articular margin of the second metacarpal head. Again, early demonstration of the erosion. In fact, today, one can even diagnose even before X-ray appearance by ultrasonography, these minute erosions. Another thing you can notice is periosteal reaction. In acute rheumatoid arthritis, you may get periosteal reaction of the bone, which you can see in the proximal phalanx of the fourth finger. And then in advanced rheumatoid arthritis, we get subluxations, ulnar deviations of the hands, sometimes telescoping of the metacarpal into the phalanx or interphalangeal joints. Look at the penciling of the ulna and subluxation at the wrist, marked destruction or even disappearance of some of the carpal bones. Juvenile rheumatoid arthritis, there is somehow, because of the hyperemia, there is acceleration of the maturation of the bones. Look at the carpal centers, they are big. Para-articular osteoporosis. Their epiphyses are also larger as compared to the normal child of that particular age. Again, another GRA, irregularity of the carpal bones, notice, and soft tissue swelling. Scleroderma, thickening of the skin, and then this is also called progressive fibrosis. And this, of course, is the Raynaud's phenomenon. You find the so-called KREST syndrome. C, calcinosis, or Raynaud's phenomenon. E, esophageal dysmotility. S, scleroderma or soft tissue calcifications. T, telangiectasia. This is classical of a scleroderma case, both classical appearance of the hands, clinical, and radiography. Again, progressive systemic sclerosis, look at the ulceration and calcifications in the hands, flexion deformities. Tapering of the distal phalanges. Acroosteolysis can also occur in scleroderma. Calcification of the soft tissue.